Good morning. Today I'm going to talk to you about surgery for a complete Achilles tendon rupture. In fact, I had already posted a video in the past in which I presented the minimally invasive technique, while today we will talk about the open surgery, i.e. the one performed with a longer incision of a few centimeters. The first step is obviously to make a correct diagnosis, which in the case of the Achilles tendon is really very simple and can be easily done with a clinical examination, possibly assisted by tests such as ultrasound or MRI. These two tests, and I am referring in particular to MRI, are therefore not so much useful for making a diagnosis as for helping to understand whether there is already advanced tendon damage present before the trauma, or to assess whether the tendon rupture affects the classic area, that is, between 5 and 9 centimeters above the insertion on the calcaneus, or whether the injury also affects the tendon fibers near the area where it attaches to the calcaneus bone. Once the diagnosis has been made, we are then faced with the question of whether or not to operate. In the case of the Achilles tendon, surgery is almost always recommended, as it is the only real option for restoring good functional recovery in patients while reducing the risk of the tendon rupturing again. The conservative approach, which involves the use of braces for a few weeks, has a high percentage of dissatisfaction, not only because the tendon may not heal with the right tension and therefore with the right strength, but also because of the risk of rupture in the following months. This risk is quite high, being 4 times higher than with surgery. The surgery can be performed under either general anesthesia or spinal anesthesia, which involves a painless injection in the back. For more information on minimally invasive surgery, please refer to the original video, which you will find linked at the end of this presentation. The obvious advantage of minimally invasive surgery is that it is a smaller, less invasive approach, even though the medium and long-term results are absolutely comparable. The concept of the surgery is, however, to first identify the tendon and then repair it using non-absorbable sutures so that they maintain the correct position of the broken fragments. To do this with minimally invasive surgery, we use a specific guide through which needles with suture thread are passed, which is then retrieved both from the proximal stump, i.e. the one located higher up, and from the distal stump of the tendon, i.e. the lower fragment. When we talk about open surgery, we basically mean performing the same type of operation, but with a slightly longer incision in the skin, which certainly has the advantage of offering the surgeon a better, more complete view. Although this approach may seem more aggressive, there is no real difference in terms of postoperative pain, which is actually very modest. Although I do not do this routinely, during the operation I sometimes make an additional incision, higher up than the Achilles tendon. The incision is made at the level of the gastrocnemius aponeurosis, which is a structure above 2 muscles. This structure is then cut only superficially in order to obtain less tension at the level of the Achilles tendon, ensuring correct tension at the level of the tendon stump structure, which is therefore less tense. The tendon is reconstructed using non-absorbable sutures, which are passed through the tendon both above and below using a needle. There are several types of tendon sutures, with isolated or continuous stitches. I prefer to use a continuous imbricated suture, i.e., a suture in which the thread is passed underneath after each stitch. Once we have passed the suture threads through the piece of tendon above, i.e. the one on your right, and the piece of tendon below, i.e. the one on your left, we can finally perform the suture, trying to bring the ends of the tendon closer together, avoiding them being too far apart or too overlapping. In other words, we try to give the suture the correct tension, and once this good tension is guaranteed, we can finally close the knot. The surgery is now over, and all that remains is to suture the superficial tissues and skin. To do this, we use another suture thread, which this time is absorbable, i.e., unlike the one we used before, it will dissolve over the following weeks. Once the skin has been closed, sterile, waterproof plasters will be applied and kept in place until the next dressing change, which is usually carried out after 5 or 7 days. After the dressing has been applied, a long boot splint is then put on with the foot in plantar flexion, i.e. pointing downwards. This is essential because it allows us to reduce the tension on the suture area, thus reducing the risk of suture failure. The plantar flexion, which is initially between 20 and 30 degrees, will then be reduced over the following weeks, during which time, however, the foot will not be able to bear its full weight on the ground, and you will therefore need to use 2 crutches. After the surgery, you will need to have a daily injection of low molecular weight heparin to reduce the risk of deep vein thrombosis, and this medication will need to be used for the first few weeks after the operation. There are certainly oral anticoagulants on the market, but in my practice, these are prohibited because they present more risks than benefits. Speaking of risks, I would like to remind you that, as with any surgery, there are clearly possible complications that should obviously be discussed with your surgeon. Thank you for your attention, and thank you in advance if you can subscribe to the channel.